new technologies are reinventing how we train medical teams, and they're expanding access to medical care for rural populations, for aging populations, and as you just heard, for other vulnerable populations that aren't being served in the ways that they need. Doctors are increasingly interacting with patients remotely, and new tools are making this more effective, with IoT and continuous monitoring to augment telehealth solutions wherever patients are. It's my great pleasure to introduce three distinguished experts who are really doing fantastic leadership in this field. We have Shijia Patten, who is an assistant professor at the University of California, Merced, and her research expertise includes ubiquitous computing, Internet of Things, and cyber-physical systems. Her research focuses on the acquisition, analysis, and augmentation of ambient information with very few or limited resources, with a focus on pervasive sensing, autonomous adaptation, and networked intelligence. Carolynn Patten is a neuroscientist and a physical therapist who specializes in the assessment and treatment of motor dysfunction associated with aging and adult neuropathologies such as stroke. She also directs the UC Davis Biomechanics Rehabilitation and Integrative Neuroscience Lab and is the co-lead of the UC Davis Center for Neuroengineering and Medicine. And Shijia is the IEEE Fellow and the Child Family Professor in Engineering, Electrical, and Computer Engineering at the University of California, Davis. Her research program focuses on developing data-driven approaches to design adaptive control and security detection mechanisms in different production networks, including IP backbones, wireless networks, data centers, online social platforms, and software-defined networks. So thank you all for taking the time out to share your thoughts with us. We're really looking forward to this. And so I think that as a first step, what we'd like to do is ask you to share a 3-minute introduction of yourselves and your backgrounds, and give us some perspective on what you think innovation in this space is. And we'd like to start with Dr. Patten, please.
So, as mentioned, I've already headlined my introduction. I study how the nervous system controls movement. And so taking a lead from our keynote speaker, I'd like you to think for a moment, reflect for a moment on everything you did to get here today and all of that you take for granted, whether it's the blink of an eye, you got out of a chair, you got in your car, you walked in here from the parking lot. That involves a very sophisticated level of coordination in your nervous system to do these fundamental motor tasks. Think also of things that are very meaningful to you. And so the pictures here are things that are meaningful to me. Activities of self-expression, activities of physical activity, perhaps high levels of performance, all of this engages the nervous system. And so this is what I study, and I use a combination of tools that from biomechanics, how do we look at forces, accelerations, motion of the human body, physiology, and then also brain, assays of brain activity. As mentioned, I'm a physical therapist. Clinically, that leads me to working in this domain, but I put these together to study recovery of function in people who've had a neurologic disorder, many different sources. Most of my work has looked in recovery of from stroke. And then I'm also interested in what happens in the nervous system as we age in the absence of a frank pathology. A couple of things we were prompted to talk about, well, what are our innovations? I am at the point that we do a lot of work in our lab. On your left, we have a project that we have named HEB. Our idea was to develop a closed-loop biofeedback system that would provide feedback of kinetics. These are the forces that you produce at the level of your joint when you move. This is a computationally intensive calculation that usually we have to do online, and it can take hours, days, weeks, depending on your technology. And not me, but people in my lab have worked to the point that we can calculate this in real time and provide it as a display on an iPad type of computer display. That way we can update how the patient or the individual is performing, and we can really perform meaningful learning paradigms or rehab paradigms as we move on to work with people who have motor impairments. That's in the lab. That's really not the intent of today here, but we need to be doing work at this very precise level of measurement. our holy grail in my field has been to get out of the lab and be able to get to the clinic, to get to the community, to get to places where we can get accurate information that can provide screening, insight, diagnosis, if you will. Sort of a stereotype of people in rehab that we study gait, that we study walking. Walking speed ends up being a marker that looks at, and it's a very robust measurable measure, but it is also very nonspecific. And so we don't learn a lot about why people have an atypical walking speed, if that's all we do from a smartphone or an accelerometer. Innovations in our field have advanced to the point that we can now do 3D motion analysis marker-free, markerless. And I'm showing in the center slide a picture. My team has really gotten out on the cutting edge of this. We stood up a study where we have gone out into the community. This is a picture in the Midtown Clinic in Sacramento for UC Davis Health, where we just walked up to people and said, could you spend 20 minutes? And from that, down here in the bottom panel, we are able to generate joint angles, kinematics, that are as good as what we get in the lab. This is a game changer for us, and I'm going to come back to this in a moment, talk about it. But we can now take this to clinicians. We can take this to the fire station, to the community center, and get data at this level of resolution, which can provide us good information. The third component related to this, and this work is supported by Citrus, is looking at machine learning algorithms as ways to deal with the large data sets and the computational intensivity of this. And so I'm working with collaborators in engineering to try to come up with appropriately informed algorithms. And we've come up with challenges. These people don't move normally. They move very slowly. The algorithms don't work that well. Nope, they're not bad data. This is the problem that we're studying. And so this is part of what I bring to the table. I think that what I offer for this type of environment is I'm a bridge. I'm not the person writing the algorithms, but I bring the insight and the interpretation into what these algorithms need to provide in order to be useful. I'll pass it on. Thank you.
My name is Shijia. I'm an assistant professor at UC Merced. I work in the computer science and the engineering department. So I kind of considering my job here is to put the right people together who have very different backgrounds and who have very different expertise. So I'm running the Pervasive Autonomous Networked System Lab, or PANS Lab, we like to joke about. We have 5 PhD students, some of them working on the AI machine learning method, and some of them working on the smart intelligence system and the hardware. So we hosted over 20 undergrads and the high school interns who are interested in the STEAM study. And because there are too many of them, so I didn't put everyone's picture here, but I do have 2 alumni who are here today, who is now actually running a startup that we are showing here as a post-truth. So, which is actually also a Citrus Foundry supported startup. So I was really proud of all the students who made the dream come true. So the reason we have so many collaborators is because we work on a smart system for a lot of different things, which let me talk about a little bit here. So we work on smart intelligence systems at many different scales, from personal level to building level to city level. At personal level, we were looking at miniaturing the sensors, like we can even embed sensors in your night guard or the retainer to capture your oral health information. When we put it in your clothes, integrate the sensors into your clothes, we were able to measure your muscular skeleton condition. Like a lot of things that you might do today might cause your pain tomorrow, or if you doing the computer work for a really long time with a hunchback, your muscle might change. So those we actually working with experts in the field, figure out what will be intuitive and non-obtrusive, non-intrusive way to capture those information about human. And then at the building level, we were looking at how can we sense people without being obtrusive. So that's really important, because if you are putting a camera in people's bathroom, nobody's going to use that bathroom anymore. So we are turning ambient structures like this table, this floor here, into sensors by measuring how humans interact with these surfaces and the cause of physical changes, like causing a vibration signal that can propagate and being captured by sensors. So in this way, we'll be able to allow, say, plug and play and unobtrusive sensing to capture all those human information at home, which we hope to provide a valuable guideline for doctors who are not able to monitor you 24/7, but we still want to know what might cause how you feel today. So this long-term continuous monitoring is providing a way to achieve that. Then we actually can also extend this type of human sensing to animal monitoring as well, where we're monitoring, say, whether say in the pig farm, whether the pigs are feeling okay. When they are not feeling okay, they might hurt their babies when they are nurturing them. So those are some extension work that we did in the lab with non-intrusive sensing as well. At the city level and the state level, because Merced is in Central Valley and we faces a lot of challenges there. Say for air quality monitoring, we simply do not have as many air quality sensors like Bay Area. So how do we kind of compensate? How do we still be able to acquire very fine-grained information to guide the operation to kind of enhance resilience to the climate, enhance public health overall, find the sources of the pollute? Those are some of the things that we do at the city and the state level. So the reason we have we have to collaborate with so many people at the different background is because these real world application they simply require many different domains of knowledge, and nobody is good at everything, but all together we can actually achieve a holistic solution from person level to the state level to the global level eventually. Yeah, and that's what we are doing. Yeah. Thank you, Professor Chu. Thank you.
So I was actually going to say that I'm actually a product of public education all my life. So I got my master's and PhD degree from UC Berkeley, and I joined Davis in 2001, and I have been here since. So the topic about technology for all, AI technology for all, health solutions, smart solution for all is really dear to my heart. I started out, working on topics related to internet measurements. So we didn't call it big data or data science back then, but since 2001, we have been collecting data in a non-intrusive manner from network systems and applications in order to understand what's going on, because internet has become so complex. And so back in 2014, I got very sick myself, and I actually noticed there is a huge gap between all this advance in technology in my field that make companies like Google and Amazon richer and richer. And there is a huge gap between that and the health domain, unfortunately. And so that's kind of motivated me to reach out to my colleagues at UC Medical Center in the UCD Health Campus, and I started collaborating with them. So, my goal, there are different threads of research threads in my lab. First is we would like to use IoTs and smart sensors and wearables to collect data and do continuous monitoring. But at the same time, at the back of my mind, I always wanted the solution, right, AI/ML solution, not just catered to the hospital and clinical environment, but actually kind of use the advancement in tiny AI ML or even AI on chips to make it feasible to run real-time digestion of this signal and inference model on the premise. And this can be done in a mobile clinic environment. It could be done in a home. It could be sent home with patients so that they can catch the life-critical conditions in real time. So the following, I'm sorry that the formatting somehow didn't work very well, but these are just example collaborative projects I have with the UCD Medical Center here. The first is the first project I work with is with Dr. Jason Adams and trying to look at the mechanical ventilator waveforms and try to see if the patient is fighting the mechanical ventilator machine for air because it will actually cause injury, lung injury. And so that's kind of the first project we worked on. And then later on we expanded it and looked at like over a course 6 hours or 18 hours, can we then predict and do an early detection of ARDS, which is acute respiratory distress syndrome, which is a wet lung disease. And then our prototype works very well. And it became very timely because that's the time when actually COVID hit and we actually need to properly triage the patients. But then, as I say, back to the point about I want to make it accessible for all. So all our models can run on edge device, like, for example, Raspberry Pi or PiTop or, Jetson Nano card that is as small as a credit card or even cell phone so that there is a chance of actually deploying it in a more rural areas. And with that, though, something that I have always kept in mind is that there are security and privacy issues that we need to address because medical data is very sensitive. Even the inference result, whether or not you have the disease, right? The outcome of the inference model is also sensitive. And we have done, kind of in the lab, there is one other, PhD student of mine look at this issue of cybersecurity issue in the whole AIoT ecosystem that are applied in the health domain. And we found out that, it's easy to fingerprint the family model of AI ML that you run, even with a very benign query of, system queries of what is the memory usage of your CPU and GPU. So that's kind of scary. And so we're trying to look at, ways to circumvent that. So we look at security and privacy of AI ML models, and I'm also interested in looking at privacy preserving queries, because when we query the health database, right? And you might not think twice about it, but it's easy to correlate the queries that you make to the databases that are kind of not owned by you, right? So again, how do we do private information retrieval? How do we, and then for a lot of the medical data is really small in nature because it's so hard to get an annotated label data set. So, one of the research theme in my group is designing label and data efficient learning models. And it's also part of the theme of make AI and ML accessible to all, because not all research groups, not all institutions have access to thousands of TPUs and GPUs, and they can train large language models. So how do we actually distill knowledge? How do we use pre-trained model very, very kind of efficiently to quickly help solve a particular learning task at hand? So that is also one of the core themes that in my lab. So I mentioned that the time series and EHR data is one kind of source of data that we looked at. Another project I have with Heather is actually looking at child defect, critical heart defect detection in newborns. So you look at the pulse oximeter data and then try to very quickly figure out whether or not this baby had this condition. And it's very time critical because it has to be caught in time before the newborn is discharged and go home. Otherwise, the mortality rate is really high. And again, in that case, because of the lightweight AI ML model, that we can actually afford to give these tools even to the families, and they can keep it at home in case there is like a home birth situation. And then I have projects with the Alzheimer's Disease Center looking at, pathology, image analysis, trying to basically perform a deep phenotyping of our brain, right, to understand the progression of Alzheimer's disease or dementia. And that is, we are facing with yet another type of challenges because the whole slide images that are produced by the digital scanners are gigapixel, right? So huge memory footprint. And it's really time consuming for the experts to actually annotate those slides, which is why we actually look at, a combination of techniques, semi-supervised, self-attention, as well as, trying to pre-train, use CLIP and, the large language model, but pre-train model in order to help understand, what are we looking at, how can we do this object detection really, really quickly. And I'm actually very happy to say that, I'm part of the UC Davis Center for Women's Health, Brain and Heart Health, that is led by Dr. Amparo Villalonga. And so we are focusing on making sure that in the brain bank that we looked at, actually, we have a diverse population and in representation in our data set. And then lastly, I also have a collaborative project with the Mind Institute with Dr. Sally Ozanov, trying to look at the video capture in her lab in the clinic environment of autistic children interacting with a provider. And so we are trying to help her applying computer vision techniques to detect behavior of interest for them to study the risks of ASD, and hopefully to also being able to detect and diagnose it at a much earlier age so that they can have introduce intervention earlier. So without that, I just want to mention that, I'm very, very fortunate. Throughout all this collaborative project, it's really, truly a team science. And, I appreciate my School of Medicine colleagues, like yourself, who actually are very patient in tutoring me and my lab members about the health side of things. And we actually meet in depth and we learn to speak, language on both sides. In fact, actually, Jason, always brought me and my new students, our onboarding process involved him taking us through, with him through the ICU rotation. So we see firsthand what he as a doctor has to do. And similarly with Brittany, the students who work with her had to take all her lab training so that they can hold human brains in their hand and they can understand the complications that are involved. So it has been a truly rewarding experience for me. And then similarly, we have a lot of complementary expertise locally within the College of Engineering as well that I tap into. Thank you.
Thank you. I want to follow up your talks with a couple of questions, which I think your talks started alluding to, but I'd like to dig in a little deeper. It's very clear that these real-time monitoring and AI and IoT technologies are really emerging as important innovations in health technology. What advances do you think are most promising, and what are the technical and scientific barriers that we need to overcome to get to this vision that you're working on? We'll start with you, Dr. Pan.
Sounds good. So I guess Dr. Chuni already mentioned something about the latest work on the onboard or on the edge processing. So I kind of feel that's one of the major direction that brings the computing closer to human. Because if you want a real time, right, you cannot really afford, how is my network condition? And how about all the other billions of people accessing the same data center, right? So having the computing on the edge and on the board would allow us to have the immediate outcome for the health condition that we are trying to predict. And the other thing, why we are why health application really needs a real-time application, real-time implementation is that in addition to just the known, right, one really important thing is what do we do really after we know, right? So for example, if I say, okay, the smart home system detect the fall of the elderly, if it's like not real time, yes, like 10 days later, we can receive an email saying, by the way, your grandma falls. That's horrible. So the immediate possibility to allow us to act fast, that's one of the big reasons we want real time and we want the computing on the board, on the edge, that's very close to us. Yeah. So.
Professor Chua, do you agree with Dr. Pan? Is there anything?
In fact, actually, with the advancement, like, things like AI on chip, which, I can envision that, in just a few years, a lot of this can be incorporated in your home appliances, and these are accessible. I'm talking about like cameras, right? I'm sure, how many of you have home surveillance cameras, right? And it's not far from there to have cameras like that with running all this computer vision AI. In fact, actually, I know that there are tech companies in Bay Area that are already selling this, right? They cost $15-20, but they can detect fall, right? So like elderly patients. So those will be perfect solutions for assisted living home or even private home environment. I think the key thing, if there is any technical barrier you were mentioning, potential technical barrier there could be just really trying to figure out who owns the data, where the processing is being done. So ideally, you want the processing to be done locally on the premise as much as possible so that the raw videos never leave your home, never leave the, even the clinic. But then you need to act on it, right? So there are various potential models that could be human in the loop, right? Someone actually receive an alert and quickly look at it and say, yeah, that's truly a fall. It's not a false alarm. And hence I call 911. Because the last thing you want is for the police department or 911 to be inundated with false alarms, right? That will be bad as well.
So it strikes me that as we're moving toward this space, there are a lot of actors and a lot of players in this. Are there any kind of data standards? You're an IEEE fellow. Are there any kind of data standards in this space? And, how is that helping or hindering?
That is actually one of the culture shock when I started working in the health space, because coming from the networking community, right, and you probably know, we have so many standards, right? IEEE standards, how we collect the data, because the packet, internet packet and IP packet is all standardized, right? So it doesn't matter what vendors you use, what equipment you use, you can understand the data that is generating. And there is a standard way of processing them. But it's totally different in the health industry. There is no like de facto data aggregator, for example. So each time there are new devices, medical devices that we're using to collect data, we have to almost start from scratch because there is no common API. So if there's anything, I really would like the health industry to start looking into that. Like we need a common API to generate, to really, output the data, so that it can be collected efficiently, it can be interoperable, right, with other potential other, machines or devices from other vendors as well, and it will only benefit everyone in the end. And I see that the health industry is like the infancy compared to maybe the telecom industry, 20 years ago. Because 20 years ago, only Sprint, only AT&T, only the main tier 1 ISP, right, have access to network data. But when the internet measurements community start to flourish, right, people realize that, if I can anonymize the data and have a repository that everyone can share and do research and open it up, right, it actually benefit everyone, right? The operator actually benefit from it as well because there are a lot of intelligent people producing algorithms that they can use, right, to run their network better. Similarly, I think even the equipment side of things, right? We went through the network equipment being opaque, right? Mainly the switch and the router companies know what is inside and can control everything from hardware to software, to this whole software-defined paradigm, right? With open flow that really opened up the box. So now anyone can program the router through software. And we have a lot of new innovation that come up because of the software networking paradigm. So I really, really sincerely hope that the health industry will go through that and open things up.
Professor Patten, we've heard kind of from the data and the lab side of things. You also spend time in a lab, but you spend time in a clinic. What's your take on this?
Well, to sort of go in reverse order, I completely agree. The health system is health systems are in their infancy about security, and they're all of a sudden like, oh my gosh, we have a problem. Let's just shut this down and make sure that nobody could get into it. And yes, we need to protect people's privacy, but it then is also obstructive to making these advances that are critically important. There end up being these lags. And so I 100% agree. We need to move towards standards and towards harmonization between engineering and medicine to whatever degree those conversations take place. I think one of the other things that happens in the domain of continuous monitoring is it's an exciting time. It's a heady time. You can have your smartphone, your Connect, your whatever, and you can monitor, did somebody fall or is somebody moving around their home? But what is the quality of that information? So, I think there's a need for much more sensitive evaluation. So take for an example that I hope most people will be able to follow along. If you have a condition like Parkinson's disease, you're often medicated. So people have, difficulty with their movement. They take medications, but those medications are very imperfect. So they have times that they are on and they have times that they're off. A lot of what's been happening with remote monitoring is like, this is a great remote continuous monitoring, is it helps so that patient doesn't show up at the clinic when they're having a great day and then the on period and the doctor says, everything's fine, see you next year. It allows for a much more continuous bit, but we need to be looking at it at a finer grain, not just, are you moving, are you not moving, are you present, are you not present? But there is a lot of information in what can be sensed from our wearable sensors or from better camera systems. And that can lead to more sensitive diagnosis and tracking and monitoring. So I think that it comes into the area of what's our bandwidth? How rapidly can we analyze the data, and can it be done online so that then information could be transmitted?
And so is there an aspect of like how rapidly are we doing this based in different contexts? For example, that health clinic versus the ICU could have very different definitions of real time and maybe accuracy or precision?
Well, I think real time is real time.
Okay.
And I mean, there are applications from we need a data point here to we need continuous data points for the next month, and so it depends on the question that you're asking. In some cases, it's great to get data turned around very quickly when you're at the point of service in the clinic. That's super helpful to a clinician. But there are other times it's much more important to have literally continuous monitoring. Is it on your smartwatch? And we can understand what's the regularity of your heart rate? Your heartbeat? Are you about to go into a period of AFib? Are you about to have a seizure? Something like this, that type of information you need to be monitoring on a second-to-second basis. So that's what I consider continuous monitoring.
Professor Chua, you mentioned some really terrifying findings around being able to backtrace your computation to potentially identify patients and conditions. And I think we're all thinking a lot about how AI is intersecting with privacy, and maybe nowhere is this more important than in our own personal health. How concerned should we be about this, and what should innovators be considering in this space?
So security and privacy is the heart and center, that we need to address from the start before widespread deployment. And that is just a lesson I learned from the communication networks era, right? Because when internet was first built, security and accountability is low on the priority list. So it was never built in. And I feel like since then, we have always been, playing this chicken and egg problem of, oh, there is a new security risk, we need to patch it, and so on and so forth. I hope that we learn lessons from that for smart health solutions and really be careful about rolling out solution with security and privacy built in. So the examples that I gave about, for example, home-based solution. So let's say, detecting fall, right, of elderly patients or elderly people in their home. Well, I think there's also a different grade of privacy people can tolerate. For example, if I have a very old relative and sick and they are living alone because they are stubborn, right? They don't want to live with relatives. Maybe we will kind of tolerate this privacy concerns a little bit more because their safety is more important than privacy to me and maybe to that person, right? So I think it's kind of murky. It's also challenging because there are a lot of non-technical reasoning behind what solution is best. So I don't think there is a one-size-fit-all solution in the security and privacy space. Each situation is quite different. And so if I were to say, what is my wish list or what I envision, I would like a customizable, right, security and privacy suites that go with the solutions.
Professor Patten, I saw you nodding. What are your thoughts on this issue?
Well, first of all, how big of a problem? How concerned? We should be very concerned. It needs to be. It's paramount. And I think fundamental principle. We say it in different ways, but I'm an experimental scientist. I work with human subjects. A fundamental thing with participants. It is a privilege. Mm-hmm. It is a privilege that these people participate and they share their data with us, and that needs to be respected and carried through. There are absolutely people who say, take it out there. I don't care. It's going to help. It's going to inform society. It's going to inform algorithms. That's going to help society. And that should be at their choice allowable. But we have to have some filters and people say, well, I'll do this, but I don't want my information out there. And so how can we do this? This has to happen on the developer end. Where can we have data? Can we toggle? That's too simplistic of a way to look at it. But I think we need the customizable solutions. Our science is only going to advance as we have information, but we need to not just take it and run with it. And I will just express a concern that I have because I see it happening with students and with current generation of students. Many of them, they want the data. Data science is very exciting. They want the algorithm. They don't really care where it came from. Do you have a database? I just want to do that and go with that. And I think that there is, we really need to be mindful of this. I want to go back to your talking about how you take your lab, people in your lab, part of their onboarding is to go into the clinical situation and understand what is happening. Thank you. Congratulations. That's a really important thing to be doing. A lot of the people coming up through the ranks these days are not interested. Just give me the data. It's anonymized. I want to go. And I think this is part of our job as educators to say, if you're going to work in this space, this is part of the landscape.
Professor, okay.
Sorry, I just want to add that just now, when I said that I want to appeal to the health industry to be more collaborative, I just want to clarify, I don't mean that it's data for all, right? I think we need to really look at what data can be anonymized and shared. And in the limited data scenario, I think I would like, a collaborative effort to look at potentially synthetic data generation, right, using generative AI. But that data needs to be validated as well, right? So it will need private data owner to help validate and know that those synthetic data that is generated is meaningful, it has high utility. So don't forget the utility part of the data versus privacy. So that's just what I want to add. Thank you.
Thank you. And Professor Pan, we've talked a lot about privacy as well, and you've echoed to me before some of those maybe sliding scales of privacy. Do you want to elaborate?
Right. So I guess we've been talking about the privacy of data in the digital world. So I do want to add a little bit on the physical world, because IoT system kind of bridge the digital world and the physical world. And nowadays, because we have more and more sensors in your home, like a community actually finds out a lot of things that we can do now. But the question now is, now we can, should we? So I can give you a few examples here that some of your robot vacuum cleaner might have a LiDAR on it. So if that's been hacked, they can actually hear you because your vibration, your voice would cause vibration on some surfaces that they can point it to. If you have a camera that's being placed on the surface of, like your smartphone front-facing camera, it can detect the vibration of your voice on the ceiling. So all those seemingly impossible signal, we technically nowadays, with all the AI tools, we can get this information. But then the question is, now we know we can, what should we do? So how do we kind of provide this type of information leakage? How do we even protect our physical data? Because we are human in the physical world. It's gonna be hard to say, let me stop emitting any signal now. That's almost impossible. So how do we control the physical signal that's being emitted? That's one thing that there are interdisciplinary research like using meta-surface, metamaterial that can control the information being propagated around. And I think at this era, a lot of things we simply cannot control. So in terms of privacy, in terms of the sensing system, physical system, the other thing I do want to point out is we need to educate people better about the privacy. Like 20 years ago, nobody would envision the social media like nowadays, but now, as long as you know what you're getting into, right? So you can post whatever you want online. But how about the sensors, right? Sensors in the home. We can mention that like a lot of things are less obtrusive more and more, but that doesn't mean they cannot get certain information. So how do we let the general public know the ability of these systems, or kind of the what does it mean by having a sensor? What does it mean to your privacy? How do you define your privacy? Those things, as engineers, we probably have a rough idea, but for a more generalized population, they might not know. They might not know what they get themselves into by putting a new sensor at home, right? It's supposed to help me by monitoring me without pointing a camera to the bathroom, but what does it really mean, right? So that I think we need to make the privacy more the kind of concept and the new perspective of privacy more accessible to the general population. That the people, as long as you understand what your information is being captured by the system, I think that will give people a better control on their data privacy, on their information leakage in general. Yeah.
Great. I'm going to have to go back to vacuuming my house by hand. So the emergence of these new tools and technologies have implications for how we're training the future. And you've all talked a little bit about your role as educators. This is also the Diversity in Tech Forum, and happy Women's Day to all of you and all of you. What does the future of medical science and engineering education look like to you? And what are the top priorities that you have for expanding diversity in your field? We'll start with Shijia.
I think I have the privilege working with a lot of very talented female undergrad students, and they are actually running startup now, becoming my boss. So I'm really proud. So the thing I see is one of the most important things to allow this is to show them there is a way, or show them there's an option. When I just joined the PhD program, I was joining in the Carnegie Mellon in Silicon Valley. I'm one of the first batch of female students there. And back then, it's really, think about the Bay Area like 20 or 15 years ago. If you do not have a car, if you have to bike, it's very difficult. And so when I was just started there, if say a female student have an emergency that you need to get something from a store, you need to bike for 13 minutes. So that's something that's kind of a blocker for a lot of students being on campus. But then when I visited the Pittsburgh campus, I noticed, they have for example, in their bathroom, they have tampons and everything. So then all you need to do is to tell the university, because back then they also don't have many female faculties there. So you need to let people know there's an option you can do to make female students' life easier. But all those things, it might be uncomfortable for a lot of people to speak up. And I think one of the things I was trying to do is to speak up all the uncomfortable things for other people who might not comfortable saying it, and get things, let people know there's an option, let people know there's a different way to do things. And I think that's the highest priority I put as improving the diversity in the STEM field. And because a lot of times I see students choose not to do something because there is something that's blocking them, and there is something that they fear to do. So our job as educators is to remove those fears, to enhance remove the blocker and remove the fear for the underrepresented groups. Yeah.
Professor Patten?
It's interesting. This wasn't what I thought about before I came here today, but I guess it's International Women's Day, and you brought up being in Silicon Valley 15 years ago. I'm going to reflect to being a postdoc. So I was a postdoc in a research institute at Stanford. This is 1998. And I walked into a Rehabilitation Research Engineering Center. I was the only female with PhD. I was the only non-card carrying engineer. And every time I went to a meeting, we would go around the conference table. It would be like Sesame Street. Which one of these is different? And every single time. And I'm still here. It was never easy, and it wasn't about tampons in the bathroom kind of issues. It was more bigger issues of, I'm a person too, I have a life, I have a family, but we couldn't talk about this at work. There was no space for that. So I am very proud right now, one of the biggest career achievements I'm proud of are a number of my students. And I had, for a long time, had a picture on my website, 3 engineers, all female, who are people running the show in my lab and smarter than I am and things like that. But I really have contributed, I hope, to developing in that regard with diversity. And I think that I'd also like us to open our filters on diversity, that it's not just racial and ethnic, it's not just gender. There are a number of flavors of diversity, and this is really the point of it. We all champion those, but our medical school has been big at addressing this issue in trying to do it without there being, explicit affirmative action. And they've come to saying, they developed this phenomenon they call the distance traveled score. Essentially, what are the barriers that people have had to overcome to get to higher education? And can we enable people who might not be looked at otherwise? And so I look at this, you probably all look at me and say, she's not diverse. She's a white woman with a PhD and full professor and so forth. But I am a first-generation female. I have a physical disability. I have come from a disadvantaged background. And that, in many ways, is a highly diverse representation that we really want to embrace here at UC. And so I try to be open to that and really make room for that in my educational experiences.
Thank you. Professor Chua?
I echo what Carolyn is saying, that I think we need to really treat diversity as, the broad definition of diversity is no longer just, it's not just gender, right? And it's not just racial ethnicity, it's also socioeconomical and other type of disadvantages that, some people face, and some people face more challenges than the other people. And we just have to be understanding of how that experience translate to blockers and barriers that we otherwise wouldn't even think about, right? So, I'm also first-gen faculty, and my parents actually never had a chance to receive any formal education. And so that's why I'm here. I'm really, it's dear to my heart in a public education mission. So in terms of how to promote diversity, throughout my stay at UC Davis, I participated and I was a program director for several of our GAN grants from Department of Education that really geared towards recruiting and retaining students from underrepresented groups. With the hope that kind of removing the financial burden, right, from their mind from day one, that if they want to pursue a PhD in electrical and computer engineering, they don't have to worry about the financial aspects. I think something similar is important, when you come to team science like this, right? We need to find a home where, I know that, some of our UCD School of Medicine colleagues are applying to like T32 training grants. So something similar like that would be very welcome, I guess, for some students to kind of try to look at this type of interdisciplinary research opportunity as a potential career path, because it's non-traditional for a lot of ECE and CS graduate students, for example. And then through my collaboration with the School of Medicine, I also realized that, this can go beyond just undergrad and graduate and postdocs, right? I work with a lot of junior female faculty in the School of Medicine who, some of which are first gen themselves. So I'm helping mentor them to incorporate data science and machine learning into their own research. And I also mentor, like, for example, NIH have a KL2 scholar program. So I mentor one of them. And just to make them feel welcome that, AI ML is not that scary. You don't need, to be scared by the jargon that, sometimes the engineers throw at you. Just make them feel comfortable. So that is important to me as well.
Shijia Pan, Carolynn Patten, Chua, thank you so much for joining us.
Thank you.